Good afternoon, everybody. Really excited to be here with my friend and colleague, Dr. Kukreja from the University of Colorado, to cover a lot of the really exciting landmark data that was presented here at AUA 2025 for bladder cancer. So we're going to get right into it. The focus of this discussion is going to be a readout of some really kind of landmark trials in the high-risk non-muscle invasive bladder cancer space. And we'll cover treatment-naive high-risk non-muscle invasive disease, and we'll cover BCG unresponsive, both CIS with or without papillary, and then some papillary-only cohorts that were reported out at AUA as well. So let's start with treatment-naive high-risk non-muscle invasive bladder cancer. This is the CREST trial. It's a phase 3 trial comparing BCG, including both induction and maintenance using the traditional SWOG 6+3 protocol, versus BCG with sasanlimab, which is an intradermal IO agent. Most of us in the room are urologists, so there's some practicality considerations with an intradermal IO approach. And this is treatment-naive high-risk non-muscle invasive bladder cancer. And primary endpoint in this trial was event-free survival. So we saw a positive press release on this trial before the AUA several months ago, and now we have the data. So Dr. Shore presented the data on Saturday at the plenary, and you can see that the combination of BCG with sasanlimab improved disease-free survival compared to BCG alone. Couple kind of take-home points for this trial. Obviously, the combination IO and BCG improved DFS in the treatment-naive setting. There was some subgroup analysis that suggested that the patients that benefit the most from the combination approach are those with CIS and T1, so maybe the higher risk treatment-naive patients. There was an arm of the trial that included sasanlimab with BCG induction only with no maintenance, and those patients did not perform well. So that kind of confirms what we already know about BCG, and that maintenance is very vital for a durable response. And lastly, sasanlimab, as I mentioned, it was dosed Q4 weeks intradermally, but it was associated with a higher rate of treatment-related adverse events, including one death from myocarditis in their cohort 2 group. So, Dr. Kukreja, what are your thoughts about therapeutic intensification in the treatment-naive setting? We know BCG works, it's efficacious, and now we're trying to, add some agents to that to increase durability in CRs.
Yeah, I mean, I think this study is really provocative. When we start thinking about how urologists have approached bladder cancer for such a long time, BCG has been such a staple, so it makes sense to start adding stuff for those prolonged responses. But at the same time, I think it was going to present a real logistical challenge. When you look at the adverse events that are associated with IO, the logistical challenge that it's going to present on our offices with the calls from patients and the monitoring and everything, and who's going to give it. And so I think the idea of this study is that they wanted to pair it with BCG, so urologists were going to give it. And I think it's going to be a transition time in urology and really decide, is this going to be something we're going to do?
Yeah, I think there's going to be a lot of provider-facing and patient-facing education materials that are going to have to be provided, and training our staff to deal with these complications for sure. So let's move on to the BCG unresponsive CIS category with or without papillary disease. These are the treatment category for which the FDA has approved single-arm registrational trials. So we saw 3 exciting trials report out. QUILT 3032 was a prospective registrational trial looking at the combination of BCG with Anktiva, which is an IL-15 superagonist to kind of augment the inflammatory reaction of the BCG in BCG unresponsive CIS. We have FDA approval for Anktiva currently for BCG unresponsive CIS in this disease space, but we got to see some durability results reported by Sam Chang. You can see that the combination of BCG with Anktiva resulted in a 71% CR at any time, and you can kind of compare that with some of the other novel agents that we'll present next. But what's most promising about this combination is the duration of CR, extending beyond 50 months and ongoing. So this is likely mechanistically explained by what we think are memory T cell activation with the addition of the IL-15 superagonists. Next, Bond 3 Cohort C reported, and this was reported by Mark Tyson. This is a single-arm registrational trial of cretostimogene in BCG-unresponsive non-muscle invasive disease. Creto is an adenoviral vector that contains a GM-CSF transgene, and it selectively replicates in RB-deficient bladder cancer cells, and that selective replication may have to do with a very favorable toxicity profile for this drug that we'll talk about. The drug is dosed very similar to BCG with a 6-week induction followed by maintenance and a primary endpoint CR. So these are kind of the landmark results for the CIS cohort. You can see that cretostimogene resulted in a 76% overall survival, overall CR with a 12-month CR rate of 46%. And while we're primarily kind of focusing on this session on efficacy data, I did just want to point out, like I mentioned, this drug is very well tolerated. There was no grade 3 treatment-related adverse events and no discontinuations of the drug on the trial. So I think that's pretty remarkable. And then lastly, we saw Dr. Jacob present data from the Sunrise-1 trial of TAR-200, which is the gemcitabine-eluting pretzel device that's placed in the bladder for BCG-unresponsive CIS in cohort 2. The trial kind of boasted a best-in-class 82% overall CR. In a cohort of patients, and these notably in this trial, these patients were not allowed to be re-induced upon 3-month failure. And the 12-month CR in this cohort was 46%. So kind of takeaways from the BCG-unresponsive CIS population, these are all pivotal trials. You know, we have Anktiva approval in this space. The durability results suggest that this is an effective drug in patients who achieve a CR. They get a durable response. And based on the promising data for both cretostimogene and TAR-200, we look forward to FDA approval of these drugs in this disease space as well. So what are your thoughts? What are your take-homes?
Yeah, I mean, I think it's such an exciting time for people that treat bladder cancer. I think the things that I think about are how are we going to meaningfully sequence these, and how do we explain to patients that even in the setting of having all these different things, certain ones might be better for them for certain reasons. In the absence of biomarkers, we don't really have any way to direct us one way or another. And so I think it's going to be very interesting. And, you know, these non-muscle invasive bladder cancer talks in the office are going to take longer and longer because there's more and more options to go through with them.
I think prioritizing which drugs you bring onto your formulary is going to be a big issue.
Yeah, and I mean, I think logistically, you know, some treatments might make more sense for some patients than others. You know, I think it depends on your patient population. It depends on what your formulary is. It depends if you are a rural, you know, solo practice, or you're at a big academic center. So I think we're going to see uptakes of these drugs in different places for different reasons.
And you know, we all very much look forward to biomarker discovery in this disease setting, but I think it's going to have to be rational biomarker discovery, like proprietary to the mechanism of the drug. There's not going to be one biomarker that's going to inform which of 4 or 5 drugs you should be able to.
Yeah, I mean, like which mechanism of action is, like, what is your tumor, like tumor specific? What's going to be the best chance for your tumor responding to this mechanism?
Right. Okay, let's talk just briefly about BCG unresponsive high-grade papillary disease, TA and T1 without CIS. The FDA has not approved single-arm registrational trials in this disease space, but I think a lot of the companies that are investigating these novel drugs in BCG unresponsive disease have wisely included cohorts with papillary-only disease. So we got to see 3 of those trials report out, the same trials that I covered in the last section. In cohort B of the QUILT study, cohort P of the BOND study, and cohort 4 of Sunrise-1, we got to see papillary-only results for Anktiva plus BCG, Creto, and TAR-200. And just to kind of briefly summarize, I put these side by side, not for cross-trial comparison, but to just kind of show that there is an efficacy signal in these patients, and this is a huge unmet need for our patients currently. And we certainly will wait for more durable results to be reported from the BOND and the Sunrise study. However, we're kind of in an unprecedented situation with papillary-only BCG unresponsive disease. Currently the FDA label for Pembro and nadofaragene is only for CIS as well as Anktiva, but the NCCN does include papillary patients as a Category 2B recommendation for both nadofaragene and pembrolizumab, but Anktiva does not have that 2B designation right now. So that does have implications on reimbursement and getting your patients on these drugs. But based on the papillary-only cohort data presented by in the Quilt study, there is going to be an application for an FDA label change for Anktiva to include papillary-only patients. However, the FDA has previously made it abundantly clear that they think that papillary-only patients should be studied in a prospective randomized trial because of the urologist's ability to completely eradicate tissue or the tumor with an adequate TURBT. So, the big elephant in the room is the FDA going to reconsider this position? What are the unmet needs for papillary-only patients in your mind?
Yeah, I don't think anybody has any idea what's happening at the FDA right now. But I think, the response rates just really highlight that these are two different diseases. While they all fall under this category of non-muscle invasive disease, CIS is different than papillary. And papillary alone is different. I think it's great that we're seeing such good response rates. But I do think the FDA is probably going to consider that these as two separate entities.
Lastly, from a clinical trial standpoint, we wanted to share the initial results from the Sisto study. And I know, Janet, you were part of this study. And we've all been, really eagerly awaiting the results from this descriptive study. So this was a prospective observational study evaluating patient-reported outcomes as a primary endpoint in patients electing to either undergo bladder-sparing therapies intravesically or radical cystectomy who have failed BCG. And this was presented by John Gore. And interestingly, and I think in contrast to most of our hypotheses who do cystectomies or manage these patients, radical cystectomy was broadly associated with higher scores in most of the patient-reported outcome domains compared to bladder-sparing therapy. And this included general quality of life, emotional well-being, and financial well-being. There were two domains that did favor bladder-sparing therapy, and that's not a surprise. It was bowel health and sexual function. But again, most of the other kind of global functioning indices did favor radical cystectomy. So what are your impressions of this data? How, in the light of these novel agents reporting out and giving us, second, third, fourth, fifth line treatments intravesically to try to spare bladders, how do you contextualize this data, and how might it change your patient, perspectives?
Yeah, I think it's really important that we highlight the hypothesis was that bladder sparing was going to be the winner. And so it was actually statistically disproven, and there was high signals that there was favors for radical cystectomy. So the way it was statistically designed was very thoughtful. Andy Smith and John Gore put this together several years ago, got some really excellent funding, and did an amazing study. And I think this is all helpful for us to understand, on a broad range. It's not just one patient that wants to spare their bladder. Those patients exist. We all see them. We all know that they're out there. But this gives us an idea of what are those several years down the line, how are they feeling? But it seems that they are mentally better, financially better, they're fully recovered, they're cognitively functioning, they're good. Right. And so it's somewhat validating to know that in the setting where we have stuff that sometimes doesn't work, that cystectomy is still a very reasonable option, and that we're actually helping people.
Yeah, I think it's also important to note that these are self-selected patients. These are patients that elected to undergo cystectomy. There's lots of, good data to suggest that you cannot feasibly or ethically randomize a patient to bladder-sparing therapy or cystectomy. So this is the best, level 1 evidence that we have in the absence of a prospective trial.
Yeah, I mean, I think what it's going to come down to is eventually we're going to have to say, all right, you're going to do, whatever first line, whatever second line, and then, third line. This is a group of patients that are very highly cured by this surgery, and it turns out that they actually do really well with this surgery. So it's going to be kind of what is the standard of care going to end up, and all of the things that I think we've talked about are going to have a role in that.
So we're going to shift gears from clinical trials and talk about some pivotal biomarker discovery work, and this may kind of go back to the sequencing question and inform that. So we're excited to see some of this work emerge. This is computational histologic AI, or CHI, and this is a AI-based histopathology platform that looks at histomorphic characteristics when you scan an H&E slide from a patient's TURBT, and it can help risk stratify patients among various disease categories within high-risk non-muscle invasive bladder cancer. The study I'm showing here was previously published and helps us predict response to BCG in high-risk treatment-naive non-muscle invasive bladder cancer. There were 3 specific abstracts that used this AI-based histopathology biomarker from Valor Labs. The first was presented by Roger Lee that looked at the biomarker's ability to further risk stratify intermediate risk non-muscle invasive bladder cancer, which, as we know, is an incredibly heterogeneous disease state. And certainly there's a lot of efforts to substratify intermediate risk patients through the IBCG and others. There's also been a recent emphasis on substratifying high-grade TA disease, and there's currently some guideline discordance. There's one thought that all high-grade tumors are high risk, but we know that the AUA guideline includes, unifocal small high-grade TA as intermediate risk. So substratifying high-grade TA disease is also of significant interest. This was an abstract presented by Sam Chang that showed that this biomarker also helps risk stratify high-grade TA patients better than the AUA risk group. And lastly, Vig Pakiam presented the biomarker's ability to potentially help select patients for first-line intravesical treatment, BCG versus gemdosi, in the treatment-naive setting. And this work was published right before the AUA started last week in EU Oncology. So the take-home from this biomarker work, this AI histopathology biomarker and this Valor Labs, biomarker assay is not the only one that's being evaluated, but it's, they presented some really compelling data here at the AUA. But it can help us risk stratify high-risk non-muscle invasive bladder cancer patients. It can help us potentially select BCG versus gemdosi. I know that this biomarker is going to be studied in the bridge trial patients, which will be very, very informative, I think. It is a commercially available assay. The test is called Vesta from Valor Labs. There also appears to be a role for the use of these AI histopathology biomarkers to kind of augment clinical risk stratification using traditional factors like tumor size and focality in high-grade TA patients as well as intermediate risk non-muscle invasive bladder cancer patients. So, Janet, kind of wonder, what are your thoughts about AI histopathology? Where, how do you incorporate these things in your practice? How do we further build upon this momentum?
Yeah, I think this is excellent work. I think AI is definitely going to have a role. I think AI histopathology is very exciting. I think the idea that we can help patients make decisions on their tumors is awesome. The logistics and how it works and how long it takes for things to turn around and all that stuff is going to really matter. But I think a lot of work still to be done, but really promising start.
Agreed. Lastly, this is we didn't want to just include non-muscle invasive bladder cancer, so this is a locally advanced and metastatic disease abstract. This is a Mayo Clinic institutional series investigating consolidative nephroureterectomy and or radical cystectomy in locally advanced or metastatic urothelial patients after systemic therapy. So this included 23 patients, most of which received EV Pembro. And this is a highly selected cohort because these patients ended up moving on to surgery, obviously. But there was, as expected, high rates of radiographic response. But I think what caught my eye was, in upwards of 50% of patients that presented with metastatic disease, received systemic therapy, and then underwent consolidative cystectomy or nephroureterectomy, there was a complete pathologic response. So that's very exciting. And I think we're ushering in a new phase of managing these locally advanced and metastatic patients who traditionally just, were completely out of the surgeon's wheelhouse at the time of diagnosis. But, are you surgically consolidating patients that have a good radiographic response? Are you using any biomarkers like ctDNA or anything else to kind of inform those patients that you're going to consolidate?
I think this highlights the need for a clinical trial in this area. I am occasionally surgically consolidating if they have a complete response. Eventually those patients want to come off therapy, right? And if they have a complete response, there is justification for at some point stopping therapy and getting them essentially returned to normal. I think ctDNA has yet to make it into NCCN guidelines and stuff like that, and I think ctDNA is still having its story written. I don't think it's quite ready for prime time yet, but I do think that EV Pembro definitively works in some patients, and it's going to be how do we select those patients to cure them of a disease that used to be incurable.
And anecdotally, there's a very intense desmoplastic response after EV Pembro, especially in patients with high volume nodal metastatic disease. So there's some surgical considerations here, and I've done a few upper tract patients open for that reason to do a formal RPL&D, and it was just very stuck.
Yeah, definitely surgical considerations, but in all the best ways.
Well, thank you. Just to kind of summarize, there's a lot of really promising data in the non-muscle invasive disease setting. We're trying to perform therapeutic intensification in the treatment-naive setting to get more CRs and durable CRs. And obviously, there's a lot of new exciting drugs coming down the pipeline for BCG-unresponsive CIS and papillary disease. So thanks for your attention.
Thank you.